Tuberculosis is one of the most deadly infectious diseases throughout human history, and it still causes significant burden of disease, particularly in the developing world. The emergence of resistance to first-line agents in tuberculosis severely limits the therapeutic options and threatens the ability to control the dissemination of this disease. Fortunately, in the last few years, new drugs and regimens are now emerging as important alternative against these organisms. Today, we will discuss this important topic of multidrug-resistant tuberculosis and new drugs with experts in the field. Welcome to Editors in Conversation. The objectives of this podcast is to discuss the burden of multidrug-resistant TB, define new drugs and regimens for MDR, multidrug-resistant tuberculosis, and examine the current and future pipeline for tuberculosis. This episode is brought to you by the Antimicrobial Agents and Chemotherapy Journal, available at asm.org/AAC. I'm your host, Cesar Arias, Editor-in-Chief of AAC, and this podcast is supported by the American Society for Microbiology, which publishes AAC. If you plan to publish in AAC, ASM members get up to 50% off publishing fees, so become a member now if you are not already. Visit asm.org/membership to sign up. And don't forget to check the latest issue available of asm.org/AAC with outstanding papers on mechanism of resistance, pharmacology, antimicrobial agents, epidemiology, clinical therapeutics, among many others. We also have a new collection in our website with all papers published in our section of New Perspective Antimicrobial Agents, and we have launched in a few months recently a new section of antimicrobial stewardship. So a lot of interesting thing going in AAC. Joining us to discuss this important topic are two real experts in the field. Dr. Kelly Dooley, who is professor in Addison and Scoville Junior Chair in Medicine and Director of the Division of Infectious Diseases at the Department of Medicine at Vanderbilt University Medical Center, and she was a past editor of Antimicrobial Agents and Chemotherapy. And then Dr. Sean Wasserman, who is Reader in Infectious Diseases at St. George's University of London and Associate Professor in the Division of Infectious Diseases and HIV Medicine at University of Cape Town, South Africa, and is a current editor of Antimicrobial Agents and Chemotherapy. Welcome to the program and welcome to the show to discuss this important topic. Kelly, so let's start with you. How important is the burden or heavy the burden of TB in the world?
Yeah, so great to see you, Cesar, and thank you so much for inviting me to be a part of this podcast. I'm really excited to be here, and I'm thrilled about the topic and the opportunity to bring attention to drug-resistant tuberculosis. But just with regards to TB generally, you would think that after this bug being with us for 3,000 years or more, that we would finally have a handle on it, and yet, unfortunately, we do not. Even this year, there were 10 million new cases in the world. And in 2014, TB overtook HIV as the number one infectious diseases killer on the planet. In the last couple of years, COVID-19 has taken its place in that number one seat. But we have seen for the first time in decades an increase in mortality from TB in the last couple of years, largely because public health funding has been diverted from TB to managing the SARS-CoV-2 outbreak. So it remains a big global health problem.
Yeah, I just want to follow with you a little bit about COVID-19 and TB, particularly because resources in the developing world were sort of shifted to control COVID-19 and maybe has made an impact in tuberculosis. Can you explain this relationship a little bit?
Yeah, so I think that the public health infrastructure for diagnosing respiratory diseases was often shifted to allow for the need to diagnose people with acute respiratory infections for COVID-19. And then also one of the public health messages was if you have pulmonary symptoms that you should stay home and not expose other people to those symptoms. And then there was just a lot of fear about going and getting diagnoses if one had respiratory symptoms. So I think that was several different things that have led to this increase.
Yeah, great. Sean, so Kelly just told us how important and deadly tuberculosis is. Why don't you explain to us what is multidrug-resistant tuberculosis and what becomes even a more worrisome trend?
Yeah, so Kelly has summarized the burden of tuberculosis overall. So, many millions of cases a year associated with mortality, which is the number one infectious killer. One of the main drivers of the TB epidemic, the ongoing TB epidemic after all these thousands of years, is drug resistance. And when we speak about drug-resistant TB, we really are speaking in terms of the epidemiology and the burden. We're speaking about rifampicin-resistant TB. That's the central key drug in treatment shortening for tuberculosis that is central to the standard short course treatment that we have for TB. Without the inclusion of rifampicin in a TB regimen, treatment is much more complicated, needs to be extended, and outcomes are worse. Multidrug-resistant TB, the definition refers to a resistance to both rifampicin and the other key drug, isoniazid. Isoniazid monoresistance also presents a burden in the global TB epidemiology. It accounts for about 10% of cases, also with slightly worse outcomes and different treatment required. But really the major driver of this is rifampicin resistance. And what we've been seeing more and more over the last 2 decades is additional drug resistance associated with rifampicin resistance, multi-drug resistance, which we've been terming pre-XDR and XDR TB, which we can define just now.
Okay, so just for the people who are not familiar with treating TB, we normally, as an infectious disease doctor, I use the term RIPE to treat TB, which involves the 4 drugs. Rifampin or rifampicin, as you mentioned, is isoniazid, or we call it INH sometimes, pyrazinamide, and ethambutol. So you need these 4 drugs to treat. So why do you need so many drugs to treat TB, Sean?
So when TB chemotherapy was first discovered in the late 1940s, with isoniazid and streptomycin as the kind of first drugs that were discovered, people saw that there was really rapid response to starting these drugs, right? In terms of patients feeling better, their cultures converting, chest x-rays getting better. The problem was that after stopping these drugs, there was a very high relapse rate. And it turns out that in order to cure TB, so make people feel better plus prevent relapses, prolonged chemotherapy is necessary. And in those early days, patients required, at least with monotherapy or with 2 or 3 drugs, those early drugs, they required 12 to 18 months of treatment to prevent relapse. The revolution that occurred in the 1970s was because of the discovery of rifampicin, which allowed treatment shortening to what we use today of 6 months. In fact, before that, it was 6 to 9 months. An additional drug called pyrazinamide enabled treatment shortening together with rifampicin and isoniazid up to 6 months. The 4th drug that we use, ethambutol, was really a replacement for an injectable for drug-sensitive TB at that time, which was streptomycin, and ethambutol was able to replace that mainly as a way to protect against resistance. But the 3 key treatment shortening drugs for TB are rifampicin, pyrazinamide, then isoniazid, which contributes to rapid clinical response.
Fantastic. Learning a lot. Kelly, you gave a really great talk here last week in Houston about the evolution of antimicrobial resistance in tuberculosis. So can you tell us a little bit about how this resistance has evolved through time to the drugs that Sean just mentioned?
Yeah, so I think it's important to know that pretty much with every drug that is introduced for tuberculosis, the time from the introduction of that drug to the emergence of resistance in some form is relatively short. So generally within a year or two of a drug becoming available for use, we start to see resistance crop up. Sometimes that's in the context of people who are already ill and having a multi-drug regimen and then adding a new drug to what is a failing regimen in the hopes of curing the patient that you have in front of you, which we all try our best to do. And then in some cases, it's a scenario where we just are not doing a good enough job of monitoring for emergence of resistance so that when it crops up, we're not necessarily detecting it. I think part of the reason for that is that we haven't done a good enough job of developing molecular resistance testing alongside the introduction of new drugs as they come on the market. And we'll talk about some of these new drugs here in a minute. So, but we just have to anticipate as a TB research community and treating clinicians that resistance will always come. And we hope for this idea of a pan-TB regimen, a regimen that can treat everyone with TB. But we know that, of course, we have to be realistic about these bugs that always find a way around the drugs that we introduce.
Following on that concept, Sean, there are several concepts about in the TB world about first line, second line, third line drug. Without getting into the new drugs, exciting drugs, what are these second line drugs that people used to do that, sometimes very toxic at third line that are sometimes even limited in certain areas of the world?
Yeah. So, first line anti-TB drugs probably refers to the ripe drugs that you mentioned earlier, right? So rifampicin-based therapy for rifampicin-susceptible TB. Once there's rifampicin resistance and that option of giving rifampicin for treatment shortening is not available, then you either need new drugs that are as potent or close to as potent as rifampicin to allow treatment shortening, or you need a combination of drugs that are less potent that require a longer period of treatment, right? The classification of TB drugs has changed over time with the emergence of evidence, so understanding how each individual drug works and in combination, and with the emergence of new drugs and drugs that have been repurposed for TB. In 2018, the WHO commissioned an individual patient data meta-analysis to analyze the effectiveness of the drugs that were available at that time. And based on the results of that meta-analysis, constructed a table of recommendations classifying the effectiveness, the relative effectiveness of the TB drugs, right? Now we have a classification system that we still use to construct TB regimens for patients with drug-resistant TB that has three categories. Category A with the most effective drugs, B with slightly less effective drugs, and category C made up of other so-called second-line drugs. None of these categories include rifampicin because the whole purpose of this classification system is for second-line treatments. And I'm sure we're going to get into discussing the individual drugs in a minute.
Yeah, so among those I just want either of you to mention about, for example, the quinolones, the aminoglycoside, and possibly the oxazolidinones. How good are these to treat TB, and how easy are to develop resistance against these drugs?
Yeah, so I can tackle that one a little bit. So as Sean was talking about, for several years, in order to treat someone with drug-resistant TB, with rifampin-resistant TB, then you would have to put a combination together of this Group A, Group B, and Group C drugs. And then when bedaquiline came on the market, it's a novel drug of the diroquinoline class, then we were able to put together regimens that included bedaquiline, which has relatively equal potency to rifampicin. And then there were regimens that were 9 to 12 months. But then came a couple of revolutionary trials. The first called NICT-TB And then on the heels of that, TB Practical and Xenix TB. And essentially what this did was usher in a short course regimen for the first time for MDR TB. And so that regimen includes bedaquiline together with Promid, one of the other new drugs that were developed this century, and then linezolid, which is a repurposed drug that we all know for treating Staph aureus and other gram-positive infections. And with that regimen, you can cure 90% of people in 6 months. There's a lot of toxicity still, the neuropathy related largely to the linezolid use, but you can cure people quite well. And then the WHO, just in the last year, really has recommended this BPAL, bedaquiline, Promid, linezolid, with a fluoroquinolone. So in some settings like South Africa, they're using levofloxacin. The trials used moxifloxacin, but that 4-drug regimen is now standard of care and has been rolled out in many settings for MDR TB. So it's incredible to with 6 months be able to treat someone with MDR TB.
Okay, very interesting. So, Sean, let's talk about bedaquiline. That seems to be like almost a miracle drug, and we are now recently starting seeing reports of bedaquiline resistance, which is like, oh my God, already the cycle. So, can you comment on this and this drug?
Yes. So bedaquiline was, I guess still is, a miracle drug for drug-resistant TB because, as Kelly says, it's got very similar potency to rifampicin. And because of that, like what I said earlier, it allows treatment shortening for drug-resistant TB. And it's therefore a central drug in our treatment for drug-resistant TB. Just to go back, up until 2018, the WHO was still recommending injectable agents for drug-resistant TB, which was a disaster for patients and for TB programs because it was painful, caused hearing loss, very difficult for patients to take. And bedaquiline effectively replaced injectable agents and enabled treatment shortening. Even before the trials that Kelly spoke about were done, in large programmatic settings, like in South Africa, it was shown that when bedaquiline was when it replaced an injectable agent for the treatment of drug-resistant TB, it actually was associated with survival benefits. So it saves lives when it's used in these regimens, and therefore it's critical. Bedaquiline has a novel mechanism of action. It's the first TB drug discovered with a novel mechanism of action probably the last 50 years, and it interferes with ATP synthesis. It's a key drug. Now, the problem is bedaquiline resistance, as you say, and as Kelly said earlier, resistance in infectious diseases, in TB specifically, is inevitable. And we are seeing emergence of resistance to bedaquiline in TB programs now. It's been used pretty extensively since about 2018, and the use is increasing, especially now with the recommendation by the WHO to use it as part of these 6-month BPAL-based regimens. Current estimates are that bedaquiline resistance prevalence is around 5%. It varies regionally. But you can imagine that if bedaquiline becomes resistant and for an individual patient and is taken out of the regimen, we go back another 10 years, right, to needing to use prolonged therapy for drug-resistant TB because that's its key role, to shorten treatment in drug-resistant TB. And so it's a huge threat to treatment for this condition and a major issue in the field.
And so can you illuminate us why this resistance is emerging? Is because of compliance or not? What are the main factors that is driving this resistant emergence?
There seems to be something particular about bedaquiline that gives it a low barrier to resistance development. One factor could be its unusual pharmacology. So bedaquiline is a drug that distributes very widely in patients. And because of this wide volume of distribution, large volume of distribution, the terminal elimination half-life of bedaquiline is extremely long. It's about 6 months. And so after patients stop taking the the other drugs, the combination drugs, together with bedaquiline. There's a long tail of bedaquiline subtherapeutic concentrations that occur after stopping TB treatment. It's been hypothesized that could be a driver for resistance emergence, although there's very limited evidence for that. And you can imagine in large TB programs where patients frequently interrupt treatment, disengage from care because of many complicated factors, that patients who have not yet sterilized their TB or culture converted have a long period of exposure to subtherapeutic bedaquiline concentrations, which could put them at risk of resistance. There also is another reason, and that is the mechanism of resistance to bedaquiline, which is not mainly target-driven resistance. It's off-target. It's based on efflux pump, which is a resistance mechanism across drug classes, including other anti-tuberculosis agents, especially clofazimine, and that could also put patients at risk or isolates at risk of higher risk of bedaquiline resistance emergence.
Fascinating. Kelly, how about the P of the B-PAL, Promid? Can you tell us about this drug and possibly resistance to this drug too?
Yeah, so I think we know a bit less about that. So Promid is a nitramidazole antibiotic. So it's relative to metronidazole that we use for anaerobic infections. And it is the newest drug that has been registered for TB. And it was registered in the context of this BPAL regimen. So it's supposed to be used together with bedaquiline and with linezolid. It's challenging. We don't even at this point have a breakpoint for Promid because there is evidence that different strains, so different families of strains, have different range of MICs. So the WHO is still working with microbiologists around the world to try to put into place a standardized breakpoint so we can even define what constitutes resistance to Promid. I will say that we know pretty little about how common resistance to Promid will be, aside from having the tools to diagnose it. But because BPAL has just been introduced in most countries, even as recently as September, say in South Africa, which is one of the early adopting countries for MDR TB treatment regimens. So we have no idea how common Promid resistance is going to be now that it's being used more widely.
Okay. And in that regimen, the L is linezolid, which is a drug that I'm very familiar with, that we tend to use twice daily for gram-positive infection, particularly approved for Staph aureus. It's actually the only drug approved for vancomycin-resistant enterococci. But we know how difficult and complicated it is when you need prolonged therapy with these drugs, with side effects like thrombocytopenia, peripheral neuropathy, and others. But in this regimen, linezolid is given once daily, as I understand. What is the rationale for that change, and how has it fared in this regimen with TB patients? Sean, you want to take that?
Sure. The rationale for using linezolid at half the registered dose for gram-positive infections is toxicity, right? We know there's an exposure-response relationship with linezolid and TB efficacy. But the dose has to be reduced because it requires longer treatment than for gram-positive infections in TB. The dose has been difficult to establish in TB because, and just like many doses of drugs for anti-TB treatment are difficult to establish because it's given as part of a combination regimen, right? And so it's hard to find that relationship between exposure and response to optimize the dose. The dose has now really, there's evidence that is supporting it finally, and that comes from a trial that Kelly mentioned earlier called Xenix, where investigators randomized patients to different doses of linezolid within the BPAL regimen framework and found that a dose of 600 milligrams a day given for 6 months had the least toxicity and was associated with a similar efficacy compared to other doses, including 1,200 a day and intermittent dosing. And so really now the dose of 600 milligrams a day is established. Having said that, it is still associated with substantial toxicity, the same toxicity that we see in patients with gram-positive infections. So hematological, mainly anemia in TB patients, much less common thrombocytopenia or neutropenia, but especially bad is neuropathy. Whether it's perceived by clinicians, experienced in a mild way by patients, whatever the consequence, the interruption of linezolid occurs very frequently in TB programs. And that is a concern for the implementation of BPAL.
So great. So Kelly, how about the access of this regimen in the developing world? How difficult and expensive is this regimen? And what are the efforts to try to get access to these medications in where is needed? They are needed the most.
Yeah, I think that access up until recently has been relatively difficult. But now that the WHO has recommended BPAL with a fluoroquinolone as first-line therapy for multidrug-resistant TB, that puts in place a series of actions that allow for programs to access the combination more readily. So the Global Drug Facility, for example, will have these medications, and then countries can order them through that program. And then there's more impetus for manufacturers to be able to produce the medication so that they're then available for use. I think some countries were waiting for WHO recommendation before implementing use of these drugs. There also have been some changes in laws in certain places that now are allowing for there to be some production of these new drugs, the generic production of these drugs that will influence the prices.
Sean, any comments? Since you live in South Africa for many years, and how this is going over there?
Well, look, South Africa, as Kelly mentioned earlier, I think has been at the vanguard of implementing new treatments for drug-resistant TB, even before the evidence became available. And in fact, through programmatic use, generated evidence that translated into guidelines for treatment of drug-resistant TB. So in South Africa, access has been comparatively good. In other countries, and I'm always surprised, when I travel to other countries for work that we do on other trials and ask about their TB programs, many countries are still using injectables for tuberculosis, for drug-resistant tuberculosis, and access to bedaquiline, especially the key drug, is not universal. And I think there's still a long way to go, lots of challenges to get people access.
Okay. So, Kelly, another thing that you gave in this beautiful talk was excitement about drugs in the pipeline, maybe new oxazolidinose, new other drugs for different mechanisms of action. Can you give us an overview of the TB drug pipeline and give us this sense of optimism for the future?
Yes, no, I'm so happy you asked that. In fact, I thought that was the topic for this webinar today, so I have prepared to talk about that, and I'm glad that you asked. So yeah, I think this is a really remarkable and exciting time in TB drug development. So as we've talked about, the drugs, these first-line drugs that we use were developed in the 1950s to 1970s, and then these new drugs, the bedaquiline, delamanid, Promid, just this century. But now there are multiple drugs of multiple classes that are in the development pipeline, and it's more robust than it really ever has been. And there are more drug companies that are invested in drug development for TB than has been the case for quite some time. So I'd say there are two general strategies. So one is to develop drugs that are in completely new classes. And so there are DPRE1 inhibitors. These are cell wall inhibiting or cell wall acting drugs that are several that are in development. LURS inhibitor, that's a new strategy for drug development. Another that uses that targets the cholesterol utilization. Another that targets the energy production by MTB. So multiple totally new classes that are in clinical development, not just preclinical development. And then the other strategy is to try to improve the therapeutic margin for drug classes that we already are using. So for oxazolidinones like linezolid, trying to develop new drugs that have equal efficacy but reduce toxicity so that clinicians and patients can use them for long periods of time without seeing the painful peripheral neuropathy and other side effects. So the oxazolidinones would be an example of that. And then the diroquinolines like bedaquiline, there are already next generation diroquinolines in development. And because with bedaquiline, you need to do cardiac toxicity monitoring, so EKGs on a relatively regular basis, that makes it challenging to use that drug in many programmatic settings. And so there have been efforts to develop newer drugs that won't require this type of cardiac monitoring because they don't cause the QT prolongation that bedaquiline does. So lots of exciting things, even things in phase 2 and phase 3 testing now.
Excellent. Sean, your opinions in many of these preclinical data actually have been published in AAC.
It's one of the strengths of AAC, of our journal, is that it also is at the vanguard of publishing a lot of the preclinical work on new drugs for tuberculosis. Yeah, I agree. I think the pipeline is richer than it has been probably ever, and lots of opportunity. One of the challenges in tuberculosis and drug-resistant TB is also not just individual drugs, but finding out what the optimal combinations of drugs are. And there are new approaches to thinking about that as well, which is exciting. I would also say that a lot of these new drugs, though, are being evaluated for drug-susceptible TBs. Kelly spoke about looking for a pan-TB regimen that doesn't require any resistance testing at the beginning of treatment, so that treatment can be deployed to as many people as possible in different resource settings without the requirements of diagnostic testing. So a lot of them are being used for drug-sensitive TB. Kelly, I'm not aware of any current phase 2C, phase 3 trials in drug-resistant TB using any of these new drugs, which is a slight concern, especially in the context of emergent bedaquiline resistance. And I think this is something that needs to be prioritized, thinking ahead. We've had these really incredible game-changing trials. One we haven't mentioned is NTB, which is going to be published soon, I hope, was presented at the union meeting, which evaluated 5 different combination bedaquiline delaminate combination regimens for drug-resistant TB around the world, and showed excellent treatment responses, right? But these are the same drugs that we're using. Bedaquiline's the key one. And I think the field needs to look at evaluating new drugs, new combinations for drug-resistant TB as well as drug-sensitive TB.
Well, Kelly, yes, please.
Yeah, no, I was going to say, it's just fascinating. So back when bedaquiline was first tested and then licensed for use, the strategy was to test a drug as an add-on. So just adding one drug to a backbone regimen to see whether you could increase culture conversion and show with a relatively small number of patients that new drug added something to what was then a pretty poorly efficacious backbone. So it was easy to show drug effect, right? So that's how bedaquiline got licensed, really. But now the strategy seems to be shifting towards testing these new drugs in different combinations in drug-sensitive TB. And I think part of the rationale for that is that you can enroll a trial involving patients with drug-sensitive TB much more quickly and readily. And so you can test multiple regimens in a relatively rapid fashion. But I do agree that we need to think about now how to treat the bedaquiline-resistant TB that is emerging. And we and others have proposed some trials, and these are in the review stages to see whether or not they will be funded and will move forward, but I think we're going to have to put several new chemical entities together in so much as we can try to understand how they will work together to be able to cure patients in the 6 to 9 month time frame. I think we can do that with new tools that are emerging and integrating preclinical and clinical data. So that so stay tuned. I think that is coming. But yes, these bedaquiline-resistant strains, they're resistant to bedaquiline, rifampin, isoniazid, pyrazinamide, generally ethambutol, and sometimes about half the time fluoroquinolone. So it's going to be tricky to treat these, and it's a real priority. And I would say that when you talk to activists and patient advocacy groups, that they put this pretty high, or if not top, on their priority list of things the research community needs to attend to.
Exciting times for TB. I think I haven't said that in a long time, so it's very good. So just to conclude this, I want to touch a little bit on latent tuberculosis, which is also something that people do on a regular basis. There have also been changes in the treatments of tuberculosis, latent tuberculosis, particularly from the 9 months of INH or isoniazid to shorter regimens. So, Sean, can you give us an overview of what's hot there and how the field has changed in treatment of latent tuberculosis?
Yeah, so we know that generally treatment of latent tuberculosis is effective at reducing incident TB. And in people with HIV, it has a mortality reduction associated as well when given together with ART. And I'm speaking about isoniazid preventive therapy. There's been a lot of advances in treatment of latent TB for prevention of drug-susceptible TB, right? So with isoniazid plus rifamycin, with increasingly shorter durations. So, up 1 month now of rifapentine plus isoniazid. Major advance in the field was announced at the union meeting a couple of months ago with the announcement of results from 2 trials that investigated prevention of drug-resistant TB, right? This was the TB CHAMP trial, which was done in South Africa, and the VQuin trial that was done in Vietnam, both giving levofloxacin, a fluoroquinolone, for 6 months to household contacts of patients with drug-resistant TB. The South African trial, the CHAMP trial, gave it to children, and the Vietnam trial gave it to adults. And the investigators phenomenally did an individual patient data meta-analysis, combining their data and reported at the same time. And combining the data from these 2 large trials, but the incidence rate is low, so you need large trials for this, showed that levofloxacin for 6 weeks reduced the incidence of TB among contacts of MDR TB patients by 60%. So really a game-changing couple of trials that are going to make their way, I'm sure, very shortly into WHO guidelines. And then there's an ongoing trial now, which Kelly can speak about, which is an ACTG trial called Phoenix, that's investigating another strategy.
Kelly?
Yeah, so thank you. So the Phoenix trial is an ACTG trial that is looking at delaminid. So we talked about Promid earlier as a new nitramidazole that's registered in the U.S. and other places for treatment of MDR TB. And then delaminid is a cousin drug, same mechanism of action, that is not registered in the U.S., but is registered in several global arenas and is in the WHO guidance for treatment of drug-resistant TB as a Group C drug. So now there's a really large, I think it's a 3,500 person cluster randomized trial looking at the use of delaminid versus isoniazid among household contacts of people who have MDR TB. And so that trial is probably 75% enrolled and is progressing towards having last patient enrolled within the next 4 to 6 months, I would say. And what will be nice if delaminid works, it will be really nice in that it's a narrow spectrum drug. And then also that will be an option for those patients who are household contacts of someone with MDR when the MDR is additionally resistant to fluoroquinolones. So this is a pretty exciting trial. We've been waiting for this to enroll and produce results for many years. So it'd be nice to see it finally fully enrolled. So fingers crossed.
Well, this has been a phenomenal conversation, letting really a lot of optimism for the future, which is sometimes not very frequently found in a field like this that affects the developing world. I want to thank you all for this fantastic and very didactic conversation, and looking forward for all the results of these trials and new develops in tuberculosis. This is Cesar Arias, Editor-in-Chief of AAC, signing off.